اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. صلى الله عليه وسلم.
Kim Yoon from South Korea. Professor Yoon is professor at Chan-Am University, National University. He is going to talk to us about femoral head preservation surgery for ABN in young patients. Professor, the floor is yours.
Okay, assalamu alaikum. Here to with a lot of friends. And this is our hospital, and so this is our another hospital. This is mainly for the focus of arthroplasty. And yes, 2 days before I came over here and did the workshop and did a live surgery. It was my great experience to be here in Al-Ghil Hospital. And it's a quite important problem in hip surgery, when you do a hip surgery, especially in young patients when there is avascular necrosis, whether we have to replace into total arthroplasty or we have to, if you can preserve the femoral head. So actually the problem of osteonecrosis is coming from interruption of blood supply. That is the main reason. And it finally leads to collapse and joint destruction. So when there's no symptom, we can think about non-surgical treatment. If the joint is really completely destroyed, then we have to do total arthroplasty. But in between, we should think about whether we should do femoral head preserving surgery or total arthroplasty. What is the indications? What do we have, like a surgical technique or something? So the main issue is the head preserving surgery, the indication, instances if you have the surgical technique. And there's a lot of things that we have to consider for the treatment of avascular necrosis. The clinical factors being age and symptoms and risk factors and socioeconomic status. For example, if the patient is like a 20, you should think about the preserving surgery. But if the patient is more than like 50, 60, then don't have to worry about too much as we do arthroplasty. Also, the radiological factors, the size, collapse, and stage is very important. So first, let's take a look at this patient. So it's the age. If it is like age under 20 years, do we have to do a total arthroplasty or do we have to do something to preserve the femoral head? Also, therefore, the younger age, when like 15, 20, this is the femoral head preserving surgery should be considered more. Also, if there is a patient, some patient has a symptom, sometimes does not have symptoms. So, like yesterday here, I found that you have sickle cell disease, and in combination with the sickle cell disease, it may not be easy to treat the femoral head. And also this Behçet's disease or renal transplantation, like if there is a background, have a severe like a problem in the hip joints, and considering the general condition is more likely to do total arthroplasty. And therefore, the methods of treatment may be changed depending on which kinds of risk factors you have. And also the socioeconomic status when you compare with the head preserving surgery and total arthroplasty. The hospital stay and rehabilitation or chances of failure may be different, so you have to choose. This patient was actually, I recommended to do like a preserving surgery for this patient, but the patient really wanted to go back to work earlier because it was not easy to get a job in Korea, so especially in economic crisis status at the time. The radiological factors, size, location, and collapse, whether it's a stage 1 or 2, 3, 4, depending on stage, we should think differently. Like when the size of necrotic area is large or medium size or small size, or the location is medially located or laterally or anterior located or posterior located, it's different. And also if it is collapse or it's a stage like a 3 and 4, it's like to do total arthroplasty, but when there is stage 2, we have to think about it. And radiological factors, so we can do more MRI or bone scan, but we do not have a uniform consensus about whether or how we can use the MRI or bone scan. Anyway, the choices of treatment, many factors are associated in the systemic and comprehensive consideration about all of the clinical and radiographic factors should be considered. And then total vasoplasty, everybody will agree that it's a really innovative and progressive and reliable surgery in the 21st century, but still they have problems like infection, dislocation, or aseptic loosening. So actually, femoral head preserving surgery should be considered first before total vasoplasty, and especially in young patients. But the key issues when we do preserving the femoral head is the two key factors, like revascularization and prevention of collapse. So there is a lot of head preserving surgeries that are reported already in the textbook and in the journals. There is a lot of methods. But when there is a lot of method, that means that there is no single best method. So I myself have done a lot of surgery method, from quasi-compression, vertebral drilling, viable bone grafting, Orthopaedic bone grafting, and Fixator bone grafting. Also, I have done rotational sterotomy, sterotomy plus bone graft, and bone grafting together with the Orthopaedic bone grafting. There was decompression was simple, but I have found a long time ago I have reported about the failure after quad decompression, so I'm not doing the quad decompression, not anymore. Also, viable bone grafting, we have used the Orthopaedic bone grafting and the Orthopaedic bone grafting. Here you see some bleeding is coming out from the bone that is attached with the muscle, and also that is attached to a vessel. So Orthopaedic bone grafting already reported, some doctors reported, and this is case showing whether we can make it survive or not. This is a 27-year-old female patient with a renal transplantation, and the MRI on the left side is quite a large one. Here, bone scan, there is a severe cold uptake, and here we found out the deep circumferential artery, and found the femoral head is already collapsed. And we tried to make a window and clear out all dead bone and put the bone in association with the pedicle, vessel pedicle. So this is a post-op X-ray and a 3-month follow-up. And in 3 months, we have checked the bone scan. We can see some increased uptake of the bone scan. This is post-op 6 months, and the post-op 6 months bone scan, we could see more uptake of the supply. And this is post-op 1 year, and 1 year we see again, 3-year follow-up, 5-year follow-up. This is a 15 years follow-up. Now I think in this patient we have about 20 years follow-up, but still we not change any into total vasoplasty. The patient could squat, and the patient could sitting cross-legged. Anyway, the lessons from Orthopaedic bone grafting, I thought the vessel, if there is a good vessel quality, we can survive. But the problem is we cannot determine whether the patient has a good blood supply or not. Take a look at this one. On the left side, we see there's a bleeding wound. But on the right side, we have a Orthopaedic, but this study, there's no bleeding. So some patients has a very poor vessel quality. So if you have a very poor vessel quality, it's not going to succeed. So the problem was some patient has a poor vessel quality, and surgery was really laborious and takes a long time. And there was severe soft tissue damage. There was in the pain cases, the patient was not happy about it. And another thing that I have thought about was Orthopaedic bone grafting, especially Dr. Baxi from India. He has done reported this kind of surgery. So I've done tensofacial lateral pedicle bone grafting. This is cases. The MRI is quite a large case, and 4 months, and 6 months follow-up, 1 year follow-up, and 2 years follow-up, 5-year follow-up. So I've thought about a new method, like using bone grafting coming from the anterior part of the gluteus medius muscle. And I have done this surgery and found many cases we have a very good healing. 1 year follow, 3 year follow, 6 year follow. Then I thought about using this is the same principle, muscle attached bone grafting. So I have thought about from the iliac crest I shifted to great trochanter. So I thought it may be easier because when we take from the iliac crest, you need a lot of long skin incision, and muscle dissection is much bigger. So I have done like this because by doing this, we could reduce the abductor problem, and also the skin incision was smaller. So this is the cases. We have muscular bone grafting from great trochanter and surgery, and this is follow, and 2 weeks follow, 1 month, 1 year, 3 year follow, 4 year, 5 year follow. Another case, it's a quite severe case, 2 weeks, bone scan increased, 3 months, that's better, 6 months follow, 1 year, 2 years, 4 years. It's quite good, like a success. 5 year follow. Also another case, this patient was like a T-cell lymphoma and found increased fatigue, 3 year follow, 7 year, 9 year, 8 year follow. So the lessons from muscular bone grafting, I found it is much easier than like a vesiculated bone grafting because it's easier to dissect the muscle. And in comparison with the muscular bone grafting from the great trochanter and from the iliac crest, in comparison with the two group, I found medius muscular bone grafting from great trochanter was less invasive and similar results. But the problem was it's still not easy to prevent the early collapse of after surgery. Because there is sometimes like 3 months, 4 months, the bone is incorporated. During the time there is a collapse occurs, then no way to make it survive. So this is the case. This I have done surgery, and post 1 week, 1 month, 3 months. But just 6 months, it was collapsed. So the patient's complaining pain again, so I had to change into total reversoplasty. So I was thinking about how we can prevent the early collapse. So prevent the early collapse, I thought we should do something like rotational therapy. This Dr. Sugioka, Fukuoka from Japan, he devised this kind of surgery. He took out the great trochanter and intratrochanteric osteotomy and detached or short external rotators except the posterior branch of the medial femoral circumcision. And maintaining the posterior branch, he rotated, and so if there is bleeding coming out. So using this method, there was quite a lot of surgeons who had success in the hip surgery in Japan and also in Korea. But the problem was stage 3 in the European countries or American, United States, some doctors tried to do that, but they all failed because they never do. So there are very few surgeons who are still doing. Some surgeons from Japan and some surgeons from Korea they are doing. So I have thought about modifying this rotational study because I thought detaching the great trochanter and reattaching the great trochanter maybe causes some problem. And also there is some cases that there is a none. So I did not detach the great trochanter. And also the direction of the screw insertion, if used like cancerous bone may be a problem. So we wanted to fix it into the cortical bone. And also I did not detach all the muscles. I maintained the quadratus femoris muscle in association with the posterior branch. So by doing a modification of this one, there's a lot of advantage because we did not detach the great trochanter, no fixation. And short operation time and the physiological biomechanics we could maintain. And if these failed cases, we could total reversoplasty a little bit easier. This is the cases. I have done surgery, rotational osteotomy, 6 months, 1 year, 5-year follow, 7, 9-year follow, 10-year follow. And he was the instructor of the Taekwondo, still doing with this. And another case, this is 6 months for 1 year, 2-year for 6. There is some like formation of the osteophyte, but still, actually it looks terrible. But the patient's symptom is quite okay. So mild pain, but still does not want to do a total osteoplasty. So then I've thought about a combination of the rotational sterotomy and bone grafting may increase the success rate. So I have done, take a look, this is only 13-year-old male patients. Had a fracture, that fracture, and post-operatively had avascular necrosis. So think about it, what kind of method we can do to make it survive. So I've thought about doing this one in combination with the rotational sterotomy and putting bone graft together. So this is the case, it's first of 1 week, 1 month, 3 months, 6 months. Take a look, gradually getting better. 3-year follow, 4-year follow, 5-year. The patients like to sit like this way. And this is another one. This is also just 15-year-old male patient. Did the bone grafting, sterotomy, 3-year follow, 7. So also combination with the rotational sterotomy plus the muscle pelvic bone grafting, because we can provide the blood supply a little bit better. This combination, but the surgery is really difficult. Takes a lot.
Next speaker is Professor Soek from Malaysia. He is a consultant of the orthopedic surgeon, University of Malaya, and he is going to talk about correction of severe genovalgus deformity. Professor. So.
Okay, thank you. First, a known case, vitamin D rickets. She was born normal, but gradually when she grew up, it becomes valgus. She has a few other family members with the same problem. All of them are short, but she has the worst deformity. She come here because it starts to be painful when she walks in school. Now, problems with the lower limb deformity includes they feel tired after walking for a while. Later, it will be painful or discomfort. Sometimes patella may become unstable, and of course, it looks not nice, ugly. With time, secondary osteoarthritis will develop, either patellar femoral joint or knee joint itself. Some cases, they are even prone to pathological fracture. Conditions can be divided, including etiology. Vitamin D resistant rickets is probably one of the most common cause in my country at least. Osteogenesis imperfecta, frequent fracture, you may have this deformity. Acquired condition like renal failure. Malunion, physeal injury on the lateral aspect may also add up with valgus or infection. Sometimes we have idiopathic causes. We do not know why. It just bent valgus. Now, by far, in our place, most of these genovalgal severe ones are due to these two: vitamin D resistant rickets and injury. Special consideration about fracture treatment, about deformity treatment. Both. Usually genovalgal contributing factor comes from the lower femur. And patellar instability more common in valgus. We don't see that much problem in varus or Blount's disease. Soft tissue, yes, this is number one. Common peroneal nerve injury, especially during acute correction. Now, for this reason, we usually try not to stretch the lateral tissue. So, second problem, tightness of fascia lata or TV, IT band is not that common because we never try to stretch this. The nerve is there. Be careful not to stretch it. And then for limb consideration, by doing closing weight or shortening, to preserve the nerve, sometimes the limb becomes shorter. This may be a problem when the opposite side is normal, so you'll have limb length discrepancy after your treatment. Then, considering the fixation part, nail, We like to use nail when the deformity is in the shaft, especially for soft bones, because we can leave the nail there to protect from further deterioration. Plate. Plate is more suitable when deformity is near to the joint, metaphyseal region. Plate can provide very accurate correction. Now, X-fit comes in when we have severe deformity or when we cannot tolerate shortening. We need to lengthen. Of course, we need the Ilizarov type of method. Now, another option which is very important is this growth guidance. Whenever possible, we should consider this because this is such a simple surgery. You put a growth plate fixation there. There's no osteotomy. You do not need to wear clutch. The child can go to school. It do not affect the life of the patient. So whenever possible, we should consider this. Now, nail fixation, again, as I said, our experience basically based on osteogenesis. Many of us, pediatric, we do OI, and then we put nail, and it is basically the same concept. Okay? So it is useful, very soft bone or fragile bone in recants, OI, and so on. But it is not suitable when the deformity near to the joint. We'll give you an example. Okay? So this is an OI case. The patient had nail in, but it defaulted for many years. Now you can see the bone is too long for the nail is too small, and some bone is already bent. So when it comes late, you have to osteotomy, straighten it. Otherwise, it's very simple. Take out a short one, put in a longer one, and continue walking. So this is 8-year-old boy, chronic renal failure, and the bone is soft, bent up like this. Now, it's high risk for surgery, and the lifespan may not be that long. Shall we consider operation, take a risk to make the bone straight? But now he hardly can walk, his knee is very painful. So now again, the bone is very soft. What implant should we use? The deformity near to the joint. Okay, so we decided then we should correct it, and with the nail, because we want to put the nail there to prevent it from bending again. So the opposite side, separate operation, straightforward, because the deformity is in the shaft, we use nail. So this is what we get. Two separate operations, taking a high-risk consent and united. Then you can see, the outcome. It's not only the appearance, it's the function. Last time he hardly can walk, but now he can walk without much pain. The improvement quality of life is really tremendous. The family feel it's worth taking the risk. Now this is a middle-aged man. He gets a malunion of the tibia shaft. This is a bit shorter. So in the shaft here, there's no open fracture, so straightforward. Corrective osteotomy, acute correction, put in the nail. Okay, looks very nice. Correction is good, fixation is good, but then after a while, this happened. Okay, the nail is pointing out, become painful. So there is a problem with nail fixation when the osteotomy or fracture near upper part of the tibia. Upper tibia nail fixation is very notorious. It cut out and a lot of problems. So eventually we convert into a plate to get a more stable fixation. Now plate can be very accurate. Now, especially with a fixed angle plate, our life is much easier. Especially for metaphyseal fixation. The only concern, soft bone, especially osteogenesis imperfecta. You put a plate, it'll just pull out. So we need a slightly stronger bone. Now this 10-year-old girl with a rickets, you get right side very severe valgus. Now at that time she's still growing, so we try not to disturb the physeal plate. So we do acute correction, just K-wire, POP cast. So it united well. You see picture, the mother also having the same problem, but not painful. So when she grew up, this is about 16 years old already. So the right side slightly valgus, the left side slightly varus. He's taking supplements so the bone is not too weak. So at this stage, final correction. Okay. Now you notice the right side is a bit longer, right? So what do we do? The right femur, valgus, we do a closing wedge osteotomy, and the left side, tibia, we do opening towards wedge. So one side longer a bit, one side shorter. Then eventually, not only you get straight limbs, the limb length is also equalized. So now this is another example to show you problem with the plating. This is a valgus, okay, and the limb is a bit short. Now we use analysis, this is where the cora, the correction. But you cannot cut here because this is the patella joint in front, patella femoral. So you have to cut a bit higher up to clear the patella. But once you cut away from the cora, you expect some translation. Now when you correct, the cortex will not be in the line. So if you use a standard distal femur plate, you will get something like this. This is common in the deformity correction, not like fracture. Fracture, when you put the pieces together, everything goes to anatomy. But for deformity, for growth arrest, the shape is different. You get the alignment right, the cortex is not aligned. You use normal plate, you get something like this, right? Now, you know, this is a dynamic compression plate. To get stability or fixation, the cortex have to touch the plate, the friction gives you stability. But now with a locking plate, they just fix it at that place. They do not need to have any contact. Now, what about compression? If you want compression over the shaft, you use here, DCP technique to compress it. So you do not need to contour the plate anatomically already. The example, 18-year-old girl, bilateral genu-valgus. Now this is the one that I showed you just now, the way she walks. This is the girl. Actual X-ray looks worse than what you see when she stands. All right. So now analyze the deformity is at the metaphysis, close to the knee joint. So severe deformity. To save the nerve, we have to do. In addition, there is also some degree of retroversion of the femur neck. So we correct this using the femur osteotomy. Now we cut this. Closing wedge is not enough. We have to shorten the femur, so to make sure the soft tissue is relaxed. And for the tibia, not too bad, so we just have simple closing wedge. So this is acute correction. We do all together at one site, one limb at a time. So this is after the first operation. Now, you look at the plate. These two plates, we do not need to contour. They are not touching the cortex. They are floating there, but this is fixed angle plate. So once we get the alignment, we want it like this, we just slide the plate, we just fix it. So it makes it much easier. Then the opposite side, the same procedure, and eventually we get the alignment correct, and the range of motion is good. This is how she walks after the procedure. Now we probably can notice that the muscle is a bit weak. It needs some physiotherapy, because when we shorten the bone, we correct all this, the muscles are become more relaxed now. So we need to tension to train the muscle to make it stronger. Now, post-operative for acute correction. After you do the surgery, although you can be careful, shortening the femur, try to preserve the nerve, but post-op, when the patient is still under anesthesia or waking up in the recovery, we have to make sure there's no injury at that time. I suspect many of these duodenal injury occurs during that time. Patient do not feel, and you put the knee full extension. When knee relaxed, the nerve is relaxed. When you put it full in the recovery room, it may actually injure there. So make sure that the knee is always flexed until the next day. Patient wake up and you see that the nerve, the toes are moving, then only you allow her to extend the knee fully. Now, what about external fixator for valgus? It can be used for metaphyseal problem or in the sharp problems, but it is not patient-friendly, not family-friendly, and not surgeon-friendly as well. A lot of work. The advantage is gradual correction, you protect the nerve, and you can lengthen the limb whenever necessary. So we know there's high complication rate, and there is no splinting effect. That means for soft bone, after you correct, take it out, there's no metal there to protect the bone. So for soft bone, this is a disadvantage. So now we have many types of external fixator that can allow the very accurate multi-axial correction at the same time. Now this is 15-year-old girl. Now severe, not that severe, but you compare with the opposite side, the difference. You compare with the other girl just now. This is unilateral. You look at the X-ray. We try growth guidance. It does not work. So the limb is short. So you do shortening and all, you have limb length discrepancy. So in this case, we decided for femur, we do acute correction, shorten the femur a bit, but for the tibia, we use external fixator, making it straight and longer so that it can get equal length. This is the final correction before frame removal, and this is after frame removal. Not only alignment correct, but the length is also equalized. Now, this you can compare with the girl just now, bilateral. Now, this is a boy. Now, we don't have a video pre-op because he already cannot walk. It is so painful, he have to use crutches or he have to hold the furniture. The knees is already very painful. The difference is that he is the only one with the disease. The whole family, he is the only one very short, the rest are normal height. And he is the only son, the only grandson in the family. So we talk about shortening, the family become worried because he looks too short. Otherwise, how to find a girlfriend or what? So we initially then discuss with them about the risk. Then we talk about, we can consider, try not to make it shorter, maybe to make it longer a bit. Yeah, nerve is still the main consideration. So the deformity is roughly the same. So what we do, yeah, femur acute correction, but for the tibia, we do gradual correction, lengthen a bit. Okay, so the fascial plate is still there. So we overcorrect into varus for the first one. Yeah, then the second one we do again. Then both sides actually it was removed already, and this is actually after the correction. Yeah, he's able to walk. Before that, he cannot walk because of painful. All right. Now the last one, growth guidance. This is a safe method of correction. Yeah, very patient friendly, but it needs to have a normal growth plate. Usually it's not for severe deformity because you cannot grow too much, okay? So there is no loss of limb function. The child after 2 weeks of operation can go to school, can play, they don't need any spleen, any BOP, no need crutches and all. So it is something that we should consider whenever it is suitable, okay? So this is child 6-year-old. He had some degree of varus. We are not sure why. The previous surgeon tried to do a corrective, doing a valgus osteotomy, but somehow it overcorrected this. So we talked to the family, say that after 1-2 years, remodeling may take care, may happen, and do not need any treatment, but they are adamant. They say they have already waited 1 year, it do not improve, it needs something to be done. But consider the child, 6 years old. Yeah? So then we told them, maybe we do something very gentle. Put a growth plate, put a fascial plate, and then let the child slowly grow out of it. So that's what we done. And after 2 years, you can see it just straightened up gradually. Now it looks like that, yeah, without major operation, without problem going to school. Now this is a 6-year-old boy, idiopathic. Now we do not know why the condition is like this. It has always like this since it's at birth. Growth plate, everything looks normal, yeah, ginovalgus. So we do a plate over here. You can see the difference, 7 years old, 8 years old, 9 years old. So now it's 10, it's about time. We wait until it's overcorrected. Again, do not cause any problem for the patient. They continue going to school. So in summary, correction for severe ginovalgus deformity is associated with the risk of common peroneal injury. So many people are very worried on this. On femur, it is safe to do a closing wedge and even shortening the femur a bit and using a locking plate to fix it inside to it. Yeah. Then for tibia, you can do acute correction, but then closing wedge, not opening wedge. Then sometimes we can consider external fixator to gradually lengthen it, especially unilateral problem. We don't want limb length discrepancy. And then for acute correction, special consideration. Yeah, after acute correction, if deformity at the shaft, you can put a nail and leave it there. If deformity at the metaphyses, you consider plate, especially locking plate. And post-op, keep the knee in flexion. Don't straighten it until the patient will wake up. Now, make sure all these deformities you discuss with the patient, with the family, of what to expect. Like the 2 examples of bilateral ginovalgus. The treatment different, not because of expertise or what, it's because of expectation. The girl, the whole family is short. Don't worry about the height and all. They just want to get it straight. And the boy, the family is very concerned about the height. So we do not want to make him shorter. So this family expectation should be considered when we plan our treatment. So with that, thank you very much.
Thank you very much, Professor Spinal Surgery. Go University Hospital, and he's going to talk to us about C1, C2 challenges. Professor David.
We asked to speak at your meeting. It's my first time in Sudan, and I've had the pleasure of working with many Sudanese doctors over the years. I'm going to talk about C1, two problems in the upper part of the pelvic spine. This is Galway in the west of Ireland. We have two Sudanese fellows at the moment. We like to make them feel at home. So we have our own mini version of the Nile. Our version is all Zulu. If they're too hot, which they frequently complain of, we can send them out to Galway Bay for a swim, and occasionally we get some snow. C21 presents a number of challenges, a number of different pathologies with instability, typically rheumatoid arthritis in Western Europe, trauma, tumour, stenosis, congenital problems, ankylosing spondylitis, and I'm sure there are other conditions here that we don't see. Particular challenges that C1 and C2 present relate largely to the anatomy, and familiarity with the bony and vascular anatomy is critical for looking after these kind of problems. The bony anatomy, we're all familiar with the posterior artery C1. This is the C1 to articulation. C2 nerve root travels just over that and sometimes gets in the way of fixation. This is C2, which is a different anatomical features to any other cervical vertebra, and the course of the vertebral artery as it travels up through the foramen, to the foramen of C1, is over the top and up into the foramen magnum. So when we think about fixation, we need, this is the sort of zone we need to be in along here at the lower part of the lateral mass of C1. There's a big venous plexus which can cause problems. We need to know the anatomy of the artery. The local anatomy of the artery in and around this part of C2 is very variable between patients and even on different sides in the same patient. Axial spine. It needs to be safe. We need to have stability in flexion and extension, and in particular in rotation, because 50% of the rotation happens at this articulation. And it needs to be versatile for different types of pathology. Looking historically, and this is not just of historical importance, I would say, Galli in 1939 introduced posterior wiring techniques. So the Galli wire was sublaminar at C1 and then passed around the spinous process of C2, which is large. The description was to remove part of the posterior part of C1 to facilitate bone graft, which is inserted between the two bones. This tends to weaken the posterior artery C1, which is a problem. And I would suggest to you this technique is still valid, and you should still know about it. It's very cheap, obviously, because the implant is just wire, but the type of wire you need to do this isn't necessarily that easily available anymore, certainly in Europe. You need something that has enough rigidity to pass it and enough flexibility to bend it without fatigue. And as well as that, you need some form of retrieval method to retrieve the wire safely. Certainly in North America, we get most of our implants from this wire has been replaced by cables, and cables don't give you that same amount of versatility in terms of use. The Brooks modification of the Galli fusion tried to increase the stability by having a bone block at each side laterally, and it did that, but at the cost of having to insert wires into the canal in C2, which is a tricky thing to do because the lamina is heading away from you, and you're putting your wire in, and it's going into the canal, which is often a tight space. So disadvantages of posterior wiring techniques: you need an intact posterior ring of C1, which isn't necessarily always available to you. The wires are going into a tight canal. You need to be very careful. You need to have the correct wire. You need to have some mechanism of retrieving it. Mechanical stability isn't great. Hardware failure is a problem. A number of posterior C1-2 clamps were developed, but none of them really were particularly good. In Switzerland, Margot, who was a general orthopedic surgeon working in St. Gallen and dealing with a lot of rheumatoid arthritis, described the Margot screw. This is a screw that goes from the C2 across the articulation into the lateral mass of C1. This is a very effective, very stable construct, very cheap to do. These are just 2 ordinary heel screws. You need to fulfill certain criteria. This needs to be reduced, this articulation needs to be reduced, and you need to consider the vascular anatomy of C2 as the screw passes through the C2 heading towards the articulation. Margaret, when he was doing this, didn't have access to CT angiography, and in actual fact he probably didn't even have access to fluoroscopy, so this was really a major development. Even in rheumatoid arthritis, you get good quality bone out laterally, even if the Untitled peg is destroyed. If you're doing it with fluoroscopy, the anterior part of C1 is your target for your screw, which generally will see the articulation under direct vision. There was a study published by Dieter Grobe in 1992 which looked at the biomechanical stability of various posterior wiring techniques and of the Margaret screw. And he found that the most stable construct was a combination of the Margaret screw, transarticular screw, plus a gallium fusion posteriorly. And this is still a valid option today. As I said, it's very cheap. Screws come into being in the 60s. The C2 pedicle screw was described by Jude, and he described the various angulations and in the sagittal and the axial plane. It's good to know these, but in reality, the anatomy is different for everybody. So the critical preoperative examination here is a CT angiogram, and to look at the particular anatomy in an individual patient and then plan your screw. In C2, the screw goes medial to the vertebral artery. This is a CT angiogram, C1, C2. This is the path of your screw, normally, and you can see that you've got high-riding vertebral arteries both sides, and this is a hostile environment to pass the screw in, and you could go for a different option. And then finally, in terms of C2 screws, the C2 laminar screw is an option. The lamina, even if the here is hostile to you, the lamina often presents a place where you can put the screw with good solid bone. It's hard to get 2 of them in. It's very easy usually to get 1 of them in, but to get 2 because they're crossing each other can be tricky. And then the position of them is in the wrong place. So that's something for you. Spend a lot of time and endanger your patient putting screws into different parts of the bone of how your tubes are going to line up. There's no point putting a screw here if you have to match it with a C1 lateral mass screw, which will be out here, and a lateral mass screw of C3, which will be out here, and you'll just find you can't possibly link them all up as a rod. So that needs to that's something you need to think about. And also, okay, we've got a C1, lateral mass screw. The lateral mass C1 is a good chunk of bone. Apart from tumors, virtually always present, even in advanced rheumatoid arthritis. To get at it is difficult. You have to go under the posterior arch of C1. Sometimes have to burr some of it away. Up along here, there is a venous plexus which gets in your way. You often see the articulation. The C2 nerve root comes out here. If it's in your way, you can just take it out. They don't seem to get any problem afterwards. Generally speaking, you can just retract it and put your screw in above it. Jürgen Harms in Germany described this type of fixation using a C1 lateral mass screw and a C2 pedicle screw. Again, you need to think about the depth of the different screws here. It doesn't really show it in this diagram, but the C1 screw is quite deep, the C2 screw is quite superficial. And then again, if you've got to link it to something in the skull or something more distant, you've got to think about it. Lateral mass is different. We're putting our screw here and going lateral to the vertebral artery. Typically, we plan it on the preoperative scan, and then in practice, if you place the drill on the spinous process below, usually you get the trajectory you need. So things to think about: local anatomy, screw depth, and alignment with other screws. And then it's important that you preserve the ligamentous attachments, particularly of C2 distally, because they're important for subaxial stability. From the front, there are a variety of C1-2 operations described in the front, none of which I've done before, but the typical one we would use from the front is your AP peg screw for fracture. And occasionally you have to go to the skull, and this is a construct showing skull fixation, wires for C1, use of axial screws, pedicle screws C2, and then lateral mass screws for axial. So which technique are you going to use? Well, you've got to look at the pathology, you've got to look at your anatomy, you've got to think about preservation of motion. You don't want to go to the skull unless you absolutely have to, for a number of reasons, preservation of motion being one of them, and you've got to think about junctional failure, what might happen at the junction of the fused and non-fused segments. So I'll just show a few cases that will illustrate some of these points. This is a lady with rheumatoid arthritis. You can see there's instability of C1, 2 on flexion extension. MRI scan, the instability reduces because she's lying down and she's got no canal stenosis. So her problem is purely instability. We do CT angiogram. So in the middle it's reduced. This is on one side on the right. You can see that there's a decent bit of bone for a transarticular screw, and the same on the left. So this is somebody where the anatomy is friendly, and she was treated with a combination of transarticular screw combined with a posterior wiring. And that's a very stable construct. This is another one. Again, C1, 2 instability. CT angiogram now is shows on the right side a little bit of subluxation, but the anatomy isn't particularly hostile in terms of the vessel. But on the other side, the higher-lying vertebral artery and the transarticular screw here is not an option. This is the axial. Again, not too bad on this side, and here certainly you don't want to be putting the screw into that area. So this situation, you can combine them. On one side you can do a transarticular screw, on the other side lateral mass C1 and pedicle screw C2, and that too is very stable. This is the third case. This patient also had C1, 2 instability, chronic changes in the core over time, just narrowed it down and showed some signal change, but she had no neurological function. This situation, however, C2 was very hostile. She's got vertebral artery in the way of your screw on both sides. This is also shown on the axial scan. So in this situation, you can totally bypass C2, go with your lateral mass C1, go down to lateral mass of C3. So fractures then. This is an elderly man, C2 peg fracture, initially managed conservatively, which we do a lot of the time, and then presented with this, a little bit of instability on flexion extension. So would you consider a peg screw? I would say not here. This gap is significant. Even though you use a lag screw to transit this into very hard bone, which is mobile with one screw, and to try and reduce that is technically very, very difficult and dangerous, I would say. So in order to use an anterior screw, you really need this to be reduced, and you don't need a gap. So we decided to go posteriorly. The plan with this man was to do posterior fixation. Lateral masses aren't great. There isn't a lot of space in here. So underneath here is your C2 root, and he's very closed down here at the back of his skull. C2 isn't an option. He's got the vertebral arteries going right through the pedicle of C2 bilaterally. But go back to the last one. There are a number of other issues here. He's fused below, so he's got congenital fusion here. He's got degenerative changes below it. But here, this presents you with an opportunity for a lot of fixation possibilities. So we had to go with this. I was trying to get a lateral mass screw in, it's bleeding, I can't see where I'm going, and it's becoming more and more difficult. C2 isn't an option. I don't really want to go to the skull. So I say to myself, well, why not go back and do posterior wiring techniques? It worked, for decades. Why is it not going to work now? We don't have that the same wire that Gary had, or that we had maybe 15 years ago. We now have cables, which are fine, but they don't really do the job that you want them to do. Anyway, I thought that we had bailed with this, sent him home, and he shows up 6 or 8 weeks later with this. I had actually merged the back of C1, which I thought was a substantial piece of bone in him in order to facilitate the bone fusion of the bone graft that I placed in, but obviously his wires gone through. And this just isn't enough. Just posterior wiring on its own isn't enough. We have to revise them to the scope. If you are going to go from the front, then there's a couple of criteria you need to think about. The trajectory is very, very steep. This can be a problem if you've got somebody with very short neck, flexed neck, somebody with a big barrel chest. So older people, you need to assess this, and you probably need to assess it with them in theatre and fluoroscopy, just to line it up, make sure you can get that trajectory. Because if you can't get it, you can't do the procedure. You need very good quality fluoroscopy for this, because that guide wire needs to be positioned absolutely accurately. In order to get this view here of the AP view, you need to open the mouth. We would normally put a cork from the bottle in between the teeth, just to open that up, and that gives you that view. If you don't do that, you're not going to see where you're going. You need to be extremely careful when you drill over the guide wire that you don't cause migration of the wire into the parental magnet. And then, above all screws, you need to think very carefully about the length of the screw, because you need to get the threads across the fracture. You need to try and get some compression on it, and there's no kind of room for maneuver here, because you want the screw to impinge on the inferior part of C2 and to tighten it down. You can't make it longer than you need to, so you need to measure it extremely carefully and get it right first time. This is a patient with upper cervical stenosis, C2, 3, 3, 4, tight, needs a wide decompression. We look at the local anatomy, you can see that C2 pedicle screw is not really going to be a great option here. So this is a good case for a C2 laminar screw. Just did one side. This isn't particularly unstable, but because it's the wide decompression, it's reasonable to fuse it at the same time and to instrument it. Going to the skull. Well, I mean, sometimes you have to. It's an easier thing to do to go to the skull because skull screws are very safe and very easy to put in, and the instrumentation is there. There are issues though. Your skull, your head typically weighs 7 kilograms, and you've fixed it now for the patient. So you need to think very carefully about the position that you fix the head in, and that's not necessarily that easy to gauge, particularly when you're on the operating table. It's very easy, and I've done it myself, to fix patients in a bad position, because where your head is, or where you think your head is, unless you actually look at patients, isn't necessarily correct. You need to think about, you have a big lever arm now, so if you go to the skull, you need to think about your distal instrumented vertebra and the stability of that, and as I said, loss of motion is a thing to consider. This lady, her first presentation with breast cancer, I think, was neck pain. She attended with neck pain and clearly has an aesthetic tumor in the lower cervical spine. She was fixed with anterior cage and plate, bone graft in here, posterior fixation to provide a tension band, and she went home with that, was happy with that for a number of years, and then she represented with this. She's now got metastasis to C2. So what do we do here? C1 is an option. C2 is completely destroyed. But there is a shed of bone around it, but there's certainly no fixation possibility. C1 lateral mass is an option, but again, you're talking about just 2 fixation points up here. Big enough operation for her. We've been in a posterior spine before, so it's a revision operation, and not necessarily that's not necessarily to be taken lightly. So in her, we did something that is unusual enough. We did a vertebroplasty of C2, which is a very straightforward thing to do. I did it more or less open. I didn't do any invasive. I did my normal approach here. And then got up to here, got a tube in, and filled with cement. And that worked well for this particular situation. Here's a gentleman with upper cervical stenosis and subaxial stenosis. This here, the back of the C2, C3, doesn't look particularly
اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. صلى الله عليه وسلم.
Kim Young from South Korea. Professor Young is professor at Chan-Am University, National University. He is going to talk to us about femoral head preservation surgery for ABM in young patients. Professor, the floor is yours.
Okay. Assalamu alaikum. Here with a lot of friends. And this is our hospital, and so this is our another hospital. This is mainly for the focus of arthroplasty. And just 2 days before I came over here and did the workshop and did a live surgery. It was my great experience to be here in our little hospital. And it's a quite important problem in hip surgery, when you do a hip surgery, especially in young patients when there is avascular necrosis, whether we have to replace into total arthroplasty or we have to, if you can preserve the femoral head. So actually the problem of osteonecrosis is coming from interruption of blood supply. That is the main reason. And it finally leads to collapse and joint destruction. So when there's no symptom, we can think about non-surgical treatment. If the joint is really completely destroyed, then we have to do a total arthroplasty. But in between, we should think about whether we should do a femoral head preserving surgery or total arthroplasty. What is the indications? What do we have, like a surgical technique or something? So the main issue is the head preserving surgery, so indication, instances if you have the surgical technique. And there's a lot of things that we have to consider for the treatment of avascular necrosis. The clinical factors being age and symptoms and risk factors and socioeconomic status. For example, if the patient is like a 20, you should think about the preserving surgery. But if the patient is more than like 50, 60, then don't have to worry about too much as we do for also, the radiological factors, the size, collapse, and stage is very important. So let's take a look at this patient. So it's the age. If it is like age under 20 years, do you have to do a total arthroplasty or do you have to do something to preserve the femoral head? Also, therefore, the younger age, when like 15, 20, this is the femoral head preserving surgery should be considered more. Also, if there is a patient, some patient has a symptom, sometimes does not have symptoms. So, like yesterday here, I found that you have sickle cell disease, and in combination with the sickle cell disease, it may not be easy to treat the femoral head. And also this Behçet's disease or renal transplantation, like if there is a background, have a severe like a problem in the hip joints, and considering the general condition, is more likely to do total arthroplasty. And therefore, the methods of treatment may be changed depending on which kinds of risk factors you have, and also the socioeconomic status when you compare with the head preserving surgery and total hip arthroplasty. The hospital stay and rehabilitation or chances of failure may be different, so you have to choose. This patient was actually, I recommended to do like a preserving surgery for this patient, but the patient really wanted to go back to work earlier because it was not easy to get a job in Korea, so especially in economic crisis status at the time. Anyway, the radiological factors, the size, location, and collapse, whether it's a stage 1 or 2, 3, 4, depending on stage, we should think differently. Like when the size of necrotic area is large or medium size or small size, or the location is medially located or laterally or anterior located or posterior located. It's different. And also if it is collapsed or it's a stage like a 3 and 4, it's like to do total arthroplasty, but when there is stage 2, we have to think about it. And radiological factors, so we can do more MRI or bone scan, but we do not have a uniform consensus about whether how we can use the MRI or bone scan. Anyway, the choices of treatment, many factors are associated in a systemic and comprehensive consideration about all of the clinical and radiographic factors should be considered. And then total arthroplasty, where everybody will agree that it's a really innovative and progressive, reliable surgery in the 21st century, but still they have problems like infection, dislocation, or aseptic loosening. So actually, femoral head preserving surgery should be considered first before total arthroplasty, and especially in young patients. But the key issues when we do preserving the femoral head is the two key factors, like revascularization and prevention of collapse. So there is a lot of head preserving surgeries that are reported already in the textbook and in the journals. There is a lot of methods. But there is a lot of methods. That means that there is no single best method. So I myself have done a lot of surgery methods, from quasi-compression, multiple drilling, viable bone grafting, Post-Operative bone grafting, and Fixator bone grafting. Also, I have done rotational sterotomy, sterotomy plus bone graft, and bone grafting together with the Post-Operative bone grafting. There was decompression was simple, but I have found a long time ago I have reported about the failure after quality compression, so I'm not doing the quality compression, not anymore. Also, viable bone grafting, we have used the Post-Operative bone grafting and the Post-Operative bone grafting. Here you see some bleeding is coming out from the bone that is attached with the muscle, and also that is attached to a vessel. So Post-Operative bone grafting already reported, some doctors reported, and this is case showing whether we can make it survive or not. This is 27-year-old female patient with a renal transplantation, and the MRI on the left side is quite a large one. Here, bone scan, there is a severe cold uptake, and here we found out the deep circumflex artery, and found the femoral head is already collapsed. And we tried to make a window and clear out all dead bone and put the bone in association with the pedicle, vessel pedicle. So this is a post-op X-ray and a 3-month follow-up. And in 3 months, we have checked the bone scan. We can see some increased uptake of the bone scan. This is post-op 6 months, and the post-op 6 months bone scan, we could see more uptake of the supply. And this is post-op 1 year, and 1 year we see again, 3-year follow-up, 5-year follow-up. This is a 15 years follow-up. Now I think in this patient we have about 20 years follow-up, but still we did not change any into total arthroplasty. The patients could squat, and the patient could sitting cross-legged. Anyway, the lessons from Post-Operative bone grafting, I thought the vessel, if there is a good vessel quality, we can survive. But the problem is we cannot determine whether the patient has a good blood supply or not. Take a look at this one. On the left side, we see there's a bleeding wound. But on the right side, we have a Post-Operative, but this study, there's no bleeding. So some patients has a very poor vessel quality. So if you have a very poor vessel quality, it's not going to succeed. So the problem was some patient has a poor vessel quality, and surgery was really laborious and takes a long time. And there was severe soft tissue damage. There was in the pain cases, the patient was not happy about it. And another thing that I have thought about was Post-Operative bone grafting, especially Dr. Baksik from India. He has done reported this kind of surgery. So I've done tensorfacial lateral pedicle bone grafting. This is cases. The MRI is quite a large case, and 4 months, 6 months follow-up, 1 year follow-up, and 2 years follow-up, 5-year follow-up. So I've thought about a new method, like using Post-Operative bone grafting coming from the anterior part of the gluteus medius muscle. And I have done this surgery and found many cases we have a very good healing. 1 year follow-up, 3 year follow-up, 6 year follow-up. Then I thought about using, this is the same principle, muscle attached bone grafting. So I have thought about from the iliac crest, I shifted to great trochanter. So I thought it may be easier because when we take from the iliac crest, you need a lot of long skin incision, and muscle dissection is much bigger. So I have done like this because by doing this, we could reduce the abductor problem, and also the skin incision was smaller. So this is the cases. We have muscular bone graft from great trochanter and surgery, and this is follow-up, and 2 weeks follow-up, 1 month, 1 year, 3 year follow-up, 4 year, 5 year follow-up. Another case, it's a quite severe case, 2 weeks, bone scan increased, 3 months, that's better, 6 months follow-up, 1 year, 2 years, 4 years. It's quite good, like a success. 5 year follow-up. Also another case, this patient was like a T-cell lymphoma and found increased uptake, 3 year follow-up, 7 year, 9 year, 8 year follow-up. So the lessons from Orthopaedic bone grafting, I found it is much easier than like a Orthopaedic bone grafting because it's easier to dissect the muscle. And in comparison with the Orthopaedic bone grafting from the great trochanter and from the iliac crest, in comparison with the two group, I found medius Orthopaedic bone grafting from great trochanter was less invasive and similar results. But the problem was it's still not easy to prevent the early collapse of the surgery. Because there is some time, like 3 months, 4 months, the bone is incorporated. During the time there is a collapse occurs, then no way to make it survive. So this is the case. This I have done surgery, and post 1 week, 1 month, 3 months. But just 6 months, it was collapsed. So the patient's complaining pain again, so I had to change into total vasoplasty. So I was thinking about how we can prevent the early collapse. So prevent the early collapse, I thought we should do something like rotational therapy. This Dr. Sugioka, Fukuoka from Japan, he devised this kind of surgery. She took out the great trochanter and intratrochanteric osteotomy and detached or short external rotators, except the posterior branch of the medial femoral circumcision. And maintaining the posterior branch, he rotated, and so if there is bleeding coming out. So using this method, there was quite a lot of surgeons who had success in the hip surgery in Japan and also in Korea. But the problem was stage 3 in the European countries or American, United States, some doctors tried to do that, but they all failed. They never do. So there are very few surgeons who are still doing. Some surgeons from Japan and some surgeons from Korea they are doing. So I have thought about modifying this rotational study because I thought detaching the great trochanter and reattaching the great trochanter maybe causes some problem. And also there is some cases that there is a non-union. So I did not detach the great trochanter. And also the direction of the screw insertion, if used like cancerous bone may be a problem. So we wanted to fix it into the cortical bone. And also I did not detach all the muscles. I maintained the quadratus femoris muscle in association with the posterior branch. So by doing a modification of this one, there's a lot of advantage because we do not detach the great trochanter, no fixation. And short operation time and the physiological biomechanics we could maintain. And if these failed cases, we could do total vasoplasty a little bit easier. This is the cases. I have done surgery, rotational osteotomy, 6 months, 1 year, 5 year follow, 7, 9 year follow, 10 year follow. And he was the instructor of the taekwondo, still doing with this. And another case, this is 6 months follow, 1 year, 2 year follow, Okay, so there is some like formation of the osteophyte, but still, actually it looks terrible. But the patient's symptom is quite okay. So mild pain, but still does not want to do a total osteoplasty. So then I've thought about a combination of the rotational sterotomy and bone grafting may increase the success rate. So I have done, take a look, this is only 13-year-old male patients. Had a fracture, that fracture, and post-operatively had avascular necrosis. So think about it, what kind of method we can do to make it survive. So I've thought about doing this one in combination with the rotational sterotomy and putting bone graft together. So this is the case, it's first of 1 week, 1 month, 3 months, 6 months. Take a look, gradually getting better. 3-year follow, 4-year follow, 5 years. The patients like to sit like this way. And this is another one. This is also 15-year-old male patient. Did the bone grafting, sterotomy, 3-year follow, 7. So also combination with the rotational sterotomy plus the muscle-pedicle bone grafting, because we can provide the blood supply a little bit better. This combination, but the surgery is really difficult. Okay, so and the posterior branch sometimes for a week do not have the posterior branch, or the typical surgical technique was the problem. So I have done actually a lot of surgical method in my experience. So I have selected, like this is my summary about how we can do preserving surgery in avascular necrosis. In selected patients, I believe it is really effective. And there's a lot of factors associated with for choosing the best treatment. Each surgeon may be different. Each patient may be different. Each surgical technique may be different. So method of surgery should be individualized. Some patients we can do, some patients not. And anyway, I think it should be considered before total osteoplasty, especially young patients. And the result depends on the patient selection, and depends on the surgeon's skill, and depends on surgical method, choice of surgical method. So anyway, if you have a good choice of method, and if you have good surgical method, surgical skill, and if you select a good patient, the patient will be happy. Thank you very much for your attention.
Next speaker is Professor Soek from Malaysia. He is a consultant orthopedic surgeon at the University of Malaya, and he is going to talk about correction of severe genovalgus deformity. Professor. So.
Okay, thank you. First, a known case, vitamin D rickets. She was born normal, but gradually when she grew up, it becomes valgus. She has a few other family members with the same problem. All of them are short, but she has the worst deformity. She comes here because it starts to be painful when she walks in school. Now, problems with the lower limb deformity includes they feel tired after walking for a while. Later, it will be painful or discomfort. Sometimes patella may become unstable, and of course, it looks not nice, ugly. With time, secondary osteoarthritis will develop, either patellofemoral joint or knee joint itself. Some cases, they are even prone to pathological fracture. Conditions can be divided, including etiology. Vitamin D resistant rickets is probably one of the most common cause in my country at least. Osteogenesis imperfecta, frequent fracture, you may have this deformity. Acquired condition like renal failure. Malunion, physeal injury on the lateral aspect may also add up with valgus or infection. Sometimes we have idiopathic causes. We do not know why, it just bent valgus. Now, by far, in our place, most of these genovalgus severe ones are due to these two: vitamin D resistant rickets and injury. Special consideration about fracture treatment, about deformity treatment. Bone. Usually ginovalgal. Contributing factor comes from the lower femur. Okay. And patellar instability more common in valgus. Yeah, we don't see that much problem in varus or Blount's disease. Okay. Soft tissue. Yes, this is number one. Yeah, common peroneal nerve injury, especially during acute correction. Now, for this reason, we usually try not to stretch the lateral tissue. So, second problem, tightness of fascia lata or TV, IT band is not that common because we never try to stretch this. The nerve is there. Yeah, be careful not to stretch it. And then for limb consideration, by doing closing weight or shortening, yeah, to preserve the nerve, sometimes the limb becomes shorter. This may be a problem when the opposite side is normal, so you have limb length discrepancy after your treatment. Then, considering the fixation part, nail, we like to use nail when the deformity is in the shaft, especially for soft bones, because we can leave the nail there to protect from further deterioration. Plate. Plate is more suitable when deformity is near to the joint, metaphyseal region. Yeah, plate can provide very accurate correction. Now, X-fix comes in when we have severe deformity or when we cannot tolerate shortening. Yeah, we need to lengthen. Of course, we need the Ilizarov type of method. Now, another option which is very important is this growth guidance. Yeah. Whenever possible, we should consider this because this is such a simple surgery. You put a growth plate fixation there. There's no osteotomy, do not need to wear clutch, the child can go to school, it do not affect the life of the patient. So whenever possible, we should consider this. Now nail fixation, again as I said, yeah, our experience basically based on osteogenesis. Many of us pediatric, we do OI, and then we put nail, and it is basically the same concept. Okay? So it is useful, very soft bone or fragile bone in brickhands, OI, and so on. But it is not suitable when the deformity near to the joint. We'll give you an example. Okay. So this is an OI case. Yeah, the patient had nail in, but he defaulted for many years. Now you can see the bone is too long for the nail is too small, and some bone is already bent. So when you come late, you have to osteotomy, straighten it. Otherwise, it's very simple. Take out a short one, put in a longer one, and continue walking. So this is 8-year-old boy, chronic renal failure, and the bone is soft, bent up like this. Now, it's high risk for surgery, and the lifespan may not be that long. Shall we consider operation, take a risk to make the bone straight? But now he hardly can walk, his knee is very painful. So now again, the bone is very soft. What implant should we use? The deformity near to the joint. Okay, so we decided then we should correct it, and with the nail, because we want to put the nail there to prevent it from bending again. So the opposite side, separate operation, straightforward, because the deformity is in the shaft, we use nail. So this is what we get. Yeah, 2 separate operations, taking a high-risk consent and united. Then you can see, yeah, the outcome. Yeah, it's not only the appearance, it's the function. Last time he hardly can walk, but now he can walk without much pain. The improvement quality of life is really tremendous. The family feel it's worth taking the risk. Now this is a middle-aged man. He gets a malunion of the tibia shaft. This is a bit shorter. So in the shaft here, there's no open fracture, so straightforward. Yeah, corrective osteotomy, acute correction, put in the nail. Okay, looks very nice. Yeah, correction is good, fixation is good, but then after a while, this happened. Okay, the nail is pointing out, become painful. So there is a problem with nail fixation when the osteotomy or fracture near upper part of the tibia. Yeah, upper tibia nail fixation is very notorious. Yeah, cut out and a lot of problems. So eventually we convert into a plate to get a more stable fixation. Now plate can be very accurate. Now, especially with a fixed angle plate, our life is much easier. Yeah, especially for metaphyseal fixation. The only concern, soft bone, especially osteogenesis imperfecta. You put a plate, it'll just pull out. Yeah, so we need a slightly stronger bone. Now this 10-year-old girl with a rickets, yeah, you get right side very severe valgus. Now at that time she's still growing, so we try not to disturb the physial plate. So we do acute correction, just K-wire, POP cast. So it united well. You see picture, the mother also having the same problem, but not painful. So when she grew up, this is about 16 years old already. So the right side slightly valgus, the left side slightly varus. He's taking supplements so the bone is not too weak. So at this stage, final correction. Okay. Now you notice the right side is a bit longer, right? So what do? The right femur valgus, we do a closing wedge osteotomy, and the left side tibia, we do opening towards wedge. So one side longer a bit, one side shorter. Then eventually, not only you get straight limbs, the limb length is also equalized. So now this is another example to show you problem with the plating. This is a valgus, okay, and the limb is a bit short. Now we use analysis. This is where the cora, the correction. But you cannot cut here because this is the patella joint in front, patella femoral. So you have to cut a bit higher up to clear the patella. But once you cut away from the cora, you expect some translation. Now, when you correct, the cortex will not be in the line. So if you use a standard distal femur plate, you will get something like this. This is common in the deformity correction, not like fracture. Fracture, when you put the pieces together, everything goes to anatomy. But for deformity, for growth arrest, the shape is different. You get the alignment right, the cortex is not aligned. You use normal plate, you get something like this, right? Now, this is a dynamic compression plate. To get stability or fixation, the cortex have to touch the plate, the friction gives you stability. But now with a locking plate, they just fix it at that place. They do not need to have any contact. Now, what about compression? If you want compression over the shaft, you use here, DCB technique to compress it. So you do not need to contour the plate anatomically already. The example, 18-year-old girl, bilateral genu-valgus. Now this is the one that I showed you just now, the way she walks. This is the girl. Actual X-ray looks worse than what you see when she stands. All right. So now analyze the deformity is at the metaphysis, close to the knee joint. So severe deformity. To save the nerve, we have to do. In addition, there is also some degree of retroversion of the femur neck. So we correct this using the femur osteotomy. Now we cut this. Closing wedge is not enough. We have to shorten the femur so to make sure the soft tissue is relaxed. And for the tibia, not too bad. So we just have a simple closing wedge. So this is acute correction. We do all together at one side, one limb at a time. So this is after the first operation. Now, you look at the plate. These two plates, we do not need to contour. They are not touching the cortex. They are floating there, but this is fixed angle plate. So once we get the alignment, we want it like this, we just slide the plate, we just fix it. So it makes it much easier. Then the opposite side, the same procedure, and eventually we get the alignment correct, and the range of motion is good. This is how she walks after the procedure. Now we probably can notice that the muscle is a bit weak. It needs some physiotherapy because when we shorten the bone, we correct all this, the muscles are become more relaxed now. So we need to tension to train the muscle to make it stronger. Now, post-operative for acute correction. After you do the surgery, although you can be careful, shortening the femur, try to preserve the nerve, but post-op, when the patient is still under anesthesia or waking up in the recovery, we have to make sure there's no injury at that time. I suspect many of these peroneal injury occurs during that time. Patient do not feel and you put the knee full extension. When knee relaxed, the nerve is relaxed. When you put it full in the recovery room, it may actually injure there. So make sure that the knee is always flexed until the next day. Patient wake up and you see that the nerve, the toes are moving, then only you allow her to extend the knee fully. Now, what about external fixator for valgus? It can be used for metaphyseal problem or in the sharp problems, but it is not patient friendly. not family friendly, and not surgeon friendly as well. A lot of work. The advantage is gradual correction, you protect the nerve, and you can lengthen the limb whenever necessary. Okay, so we know there's high complication rate, and there is no splinting effect. That means for soft bone, after you correct, take it out, there's no metal there to protect the bone. Yeah, so for soft bone, this is a disadvantage. So now we have many types of external fixator that can allow the very accurate multi-axial correction at the same time. Now this is 15-year-old girl. Yeah. Now severe, not that severe, but you compare with the opposite side. The difference, you compare with the other girl just now. This is unilateral. You look at the X-ray. We try growth guidance. It does not work. So the limb is short. Yeah. So you do shortening and all. You have limb length discrepancy. So in this case, yeah, we decided for femur, we do acute correction, shorten the femur a bit. But for the tibia, we use external fixator, making it straight and longer so that it can get equal length. This is the final correction before frame removal, and this is after frame removal. Not only alignment correct, but the length is also equalized. Now, this you can compare with the girl just now, bilateral. Now, this is a boy. Now, we don't have a video pre-op because he already cannot walk. It is so painful, he had to use crutches or he had to hold the furniture. The knees is already very painful. The difference is that he is the only one with the disease. The whole family, he is the only one very short, the rest are normal height. And he is the only son, the only grandson in the family. So we talk about shortening, the family become worried because he looks too short. Otherwise, how to find a girlfriend or what? So we initially then discuss with them about the risk. Then we talk about, we can consider, try not to make it shorter, maybe to make it longer a bit. Yeah, nerve is still the main consideration. So the deformity is roughly the same. So what we do, yeah, femur acute correction, but for the tibia, we do gradual correction, lengthen a bit. Okay, so the fascial plate is still there. So we overcorrect into varus for the first one. Yeah, then the second one we do again. Then both sides actually it was removed already, and this is actually after the correction. Yeah, he's able to walk. Before that, he cannot walk because of painful. All right. Now the last one, growth guidance. This is a safe method of correction. Yeah, very patient friendly, but it needs to have a normal growth plate. Usually it's not for severe deformity because you cannot grow too much. Okay, so there is no loss of limb function. The child after 2 weeks of operation can go to school, can play. They don't need any spleen, any BOP, no need crutches and all. So it is something that we should consider whenever it is suitable. Okay, so this is child 6-year-old. He had some degree of varus. We are not sure why. The previous surgeon tried to do a corrective, doing a valgus osteotomy, but somehow it overcorrected this. So we talked to the family, said that after 1-2 years remodeling, we take care, may happen and all, do not need any treatment, but they are adamant. They say they have already waited 1 year, it do not improve, it needs something to be done. But consider the child, 6 years old. Yeah? So then we told them, maybe we do something very gentle, put a growth plate, put a fascial plate, and then let the child slowly grow out of it. So that's what we done. And after 2 years, you can see it just straightened up gradually. Now it looks like that. Yeah, without major operation, without problem going to school. Now this is a 6-year-old boy, idiopathic. Now we do not know why the condition is like this. It has always like this since it's at birth. Growth plate, everything looks normal. Yeah, genovalgus. So we do a plate over here. You can see the difference. 7 years old, 8 years old, 9 years old. So now it's 10. It's about time. We wait until it's overcorrected. Again, do not cause any problem for the patient. They continue going to school. So in summary, correction for severe genovalgus deformity is associated with the risk of common peroneal injury. So many people are very worried on this. On femur, it is safe to do a closing wedge and even shortening the femur a bit and using a locking plate to fix it inside too. Yeah. Then for tibia, you can do acute correction, but then closing wedge, not opening wedge. Then sometimes we can consider external fixator to gradually lengthen it, especially unilateral problem. We don't want limb length discrepancy. And then for acute correction, special consideration. Yeah, after acute correction, if deformity at the sharp, you can put a nail and leave it there. If deformity at the metaphysis, you consider plate, especially locking plate. And post-op, keep the knee in flexion. Don't straighten it, yeah, until the patient will wake up. Now, make sure all these deformities you discuss with the patient, with the family, of what they expect. Like the two examples of bilateral genovalgus. The treatment different, not because of expertise or what, it's because of expectation. The girl, the whole family is short, they are don't worry about the height and all, they just want to get it straight. And the boy, the family is very concerned about the height, yeah? So we do not want to make him shorter. So this family expectation should be considered when we plan our treatment. So with that, thank you very much.
Thank you very much.
Hostile or nasty, but when we do a CT, because this is not an angiogram, this is regular CT. This is OPLF. I don't know if you see much of this in Sudan. You see very, very little of it in Ireland. I'm sure that our Korean friends will have seen lots and lots of this. This is it's very important to diagnose that, obviously, particularly if you were considering coming from the front. This individual needs a wide decompression and we went and did a fixation to the skull. Like I said, you need to look at where the head is. This isn't that same individual, this is just for the purpose of illustration. But if you look at where the head is, where it's facing, and where it rests compared to the trunk of the axis of the trunk. The head is forward. You need to look at the gaze, and what I normally do is I look at the ear, and I decide where the patient's ear should be in terms of their vision, and try to replicate that when they're on the operating table. And I found that as accurate as any other method. Okay, so in conclusion then, preoperative planning is key. You need to decide where your screws are going to go. You need to look at the anatomy locally. You need to have good imaging, and you absolutely need to have CT angiography. You definitely need to have a plan B, and you need to have that plan B worked out in advance. You don't have to work it out if things aren't working out for you on the day. Thanks very much.
Those their vast and beautiful experience. May I ask the speakers to come forward? And floor is now open for discussion. Questions?
Over the caption anteriorly and posteriorly, otherwise it does not rotate.
You?
Do that dislocation of some sort of, you try to bring the head out to graft it, or you graft inside it?
Well, yes, type of fractures. In the case I do, like a gunge dislocation with anterostomy, and it is possible. But with the abysmal necrosis, is because it's already a base graft. So I try to not to dislocate as much as possible if we can. But I think depending on the surgeon's ability of the skill, how we do it, I think that will be maybe possible.
Two questions actually. For the correction of the geniovalgus, in rachitic change, that's okay, but when do you decide to operate in patients with mucopolysaccharide disease? And the second question is for in spinal cases. In cases of Down syndrome, when do you decide to go in and fix?
Okay, so I will answer the first question. Mucopolysaccharidosis, the nature is that there's a metabolic problem. It's not just physical. Okay, the healing and all may be a big problem, higher risk of general morbidity, and the bone is also a bit short. It may deform again. Okay, so I think this is a bit similar to rickets as well, because this bone is a bit soft. Right? So the question is when we decide to operate. Now, quite often it's the patient that look for us because we would have corrected it a bit earlier. If we detect them in the early stage while they are still growing, now the physeal plate is not really a problem in either recast, mucopolysaccharidosis or what. The simplest way is to do epiphyseal control, that means growth guidance. Put a physeal plate on put a egg plate on the medial side, let it straighten by itself. Now that is always the option if they come early. If they come late, then probably acute or gradual correction is necessary. Quite often early. How early is early? Now we know limb length discrepancy is not really directly associated with long-term problem. Some people say that you have scoliosis, back pain, and what is not really true. The evidence is not strong. But varus or valgus, it is associated with premature osteoarthritis. We know many people are walking around with slight genu varum. Okay? Now, when you should ask them to operate is a bit difficult. Yeah? Genu valgum as well. So probably more than 10 degree, we will offer whether you want to correct. It's not to make, there's no change at this current moment, but the risk of osteoarthritis when they are older, 20 years, 30 years down the line, that is where the benefit can occur. So in short, yeah, the indication is actually there for varus or valgus deformity, probably more than 10 deviation, I would consider offering them. But we have to balance to the benefit. If there's severe medical problem with a short lifespan, then probably we don't need to be so aggressive. But if the lifespan is normal, yeah, I think I will offer correction.
Thank you. Down syndrome, C1-2 instability is fairly common, but for it to progress is very unusual. So I follow a lot of them. Usually there's a few millimeters of instability there. Often stabilizes as they get older and isn't a problem. Even if it doesn't progress into adulthood a lot of the time. If they're progressing, and if you can document progressive instability, then obviously you think about fixing them. But most of them, I would not operate.
Question for Professor Aiden. In your fixation for this C1, C2 stabilization, do you always just
you get into the joint. Certainly if you're doing a transarticular screw, you should get into the joint so you can see where the C2 screw exits before it goes into C1, and then you know you're safe. And those circumstances, you have the opportunity just to curette the joint surface. You don't necessarily have to put any graft on it, but you can curette it and prepare it for fusion. Distal to that, from C3 down, normally, the cervical spine fuses so easily, we don't normally spend a lot of time with the facets. But C1-2, I would normally put bone graft. And similarly, if I was using posterior wires as part of the construct, say with the two Margaret screws, I would put bone graft between C1-2. I think a lot of people don't, though. They probably get away with it, but it's you know, it's there. It's not particularly difficult to do, and obviously, you know, if it gives you a little bit more security in terms of fixation, I would recommend.
Same question for David. Do you use external support for C1, C2 fixation? Do you use any form of
Post-operatively?
Yes.
Not necessarily. We would normally give them a collar for a few weeks, more for comfort, more than anything else, and just to give them a bit of security if they go out in a crowd or somebody bumps into them. But I don't think you need it. I think you certainly, when you're finished your construct, you need to be certain that your fixation is sufficient to hold, and you're not relying on external fixation.
Thank you very much. That's the last question, and I think we have to proceed with our program. The first part of the morning is
Our first speaker is Dr. Sandy Adke from India. He works at Adke Hospital, Department of Orthopaedics, and he's going to talk about complex trauma and the use of Elizarov. Thank you.
It's my great pleasure to be amongst all of you, and I'm very grateful to the Sudanese Orthopaedic Surgeons Association, the entire organizing team, and especially Dr. Ilhadi, that he has invited me to share some of my experiences about the most wonderful system called Elizarov in the world. Friends, trauma is a very common topic nowadays, but day by day, the complexity of the trauma is increasing, and so we need to have some better planning for treating such complex patients. Big bone losses, severe deformities, non-unions, and so on and so forth. It's a big nightmare for the treating surgeon. It's kathir mushkilat. So how to tackle all these things? Most of the time, my center gets such kind of earlier, immediately treated cases, compound fractures and community fractures, but immediately landing up into such disasters like infections, non-unions, infected plates, nails, and so on and so forth. As we know, since ancient times, many treatment modalities have been formulated for treating a lot of orthopedic and trauma cases, ranging from the plates, internal fixations, then nails, plasters, and varieties of the external fixators, ranging from the AO, Orthofix, and others to Elizarov. But they have the conventional treatment modalities, they have got distinct limitations and disadvantages, like the lack of adequate and stable joint reposition, prolonged immobilization, joint stiffnesses, difficult to correct malunion, cannot correct the shortening, disability, weight-bearing disorders. This leads to delayed union or sometimes problematic to use internal implantations in cases of the infections. So that's why there is a lot of implant failure, longer hospital stay, expensive treatment costs, cosmetic disfigurement, always there is a second surgery needed for removing internal implants, lack of social rehabilitation, and longer use of antibiotics. Due to all these things, nowadays the complex trauma patients, they are being socially and economically, they have been burnt out, not only in India but every part of the world, including the Sudan also. As well as it's a really very great burden on our health system to cater such patients due to repeated surgeries, expensive antibiotics, longer hospitalization, and so on. So what is the treatment option for all these kinds of patients? This is one of the examples that these complex trauma patients, we need to open, and in spite of that, with internal implantation, they give away by the way of delayed non-union or maybe sometimes very commonly infected non-unions. Even you can see the very recent one, and the locking plates, they can fail, and you can see here the screws are back out. So which system is actually reliable to treat all these kinds of fixation? If you go to Kurgan, you will find all these things. Professor Elizarov and his followers, they have removed all the failed cases, internal implantation, and you can find this thing in the museum. Due to all these repeated surgeries, one after the other internal implantations, bone graftings, and expensive treatment costs, very often, really every day we get such kind of references from all over the world that due to the repeated surgeries, in fact, we are harming the bone more and more, and ultimately these cases they land up into such dreaded complications as non-unions. Ladies and gentlemen, I take this opportunity to welcome all of you to the world of Elizarov. Professor Elizarov in 1951 has given this wonderful system from skull to toe to tackle any bone and joint problems. It's little bit clumsy, but it's very useful, it's biological, and it has got very distinct advantages over this conventional system modality. We have got nearly 800 very highly effective techniques to treat all varieties of such complex trauma, and in nearly 80% of these cases, we treat very successfully all these cases, and in 55% of the cases, it gives much more better social rehabilitation. What are the applications of Ilizaro in such cases? Ranging from simple compound fractures, periarticular fractures, combinated fractures, short bone, long bone fractures, clavicle, polytrauma, crush and degrowing injuries, even pelvic fractures, spinal fracture dislocations, dislocations at all varieties and at all locations, sequelae like delayed malunion and non-union, shortening and deformities, infections, muscular tenderness, injuries, as well as the injuries associated with the neurovascular structure can be dealt very effectively by Ilizaro. And the main important aspect or beauty of the Ilizaro is it has got no bar. The Ilizaro system can be used at any age, in any sex, for any fracture location, anatomy and type of configuration. Maybe it might be associated with the severe bone loss or soft tissue losses, or maybe associated with the neuromuscular injuries, and it has got no socio-economical barriers. This is one of the case. You can see a grade 2 compound open fracture, upper end of the tibia. The patient came in shock to us. It's a really tricky situation. There are so many treatment options available. But once the patient got stabilized, on the very next day we debrided, cleaned the wound and sutured the wound primarily, and it was primarily fixed by Ilizaro. And see the beauty of Ilizaro. The patient started walking immediately 2.5 hours after the surgery. This is the miracle of Ilizaro, that this system is such a sturdy system that you can make the patient walk immediately. So this can happen with Ilizaro. The fracture ultimately healed up very fast. The wound has healed within 2 weeks of time, and the patient is very well rehabilitated. How such wonderful results we are getting with Ilizaro? There are distinct criteria that Ilizaro permits. It is a closed method of transosseous osteosynthesis, which gives us precise and good and firm reduction, early and complete functional activity. It has got very broad range of applications. It is minimal traumatizing to the tissue, which is already badly traumatized, and it has a very simplicity of the assembly, and it has got the capability to interchange the components later on also, as per the requirement. I like this very famous quote of the Professor Ilizaro, that every treating physician should carefully understand what I am telling. The fact that most of the patients are cured by conventional therapeutic techniques should not satisfy an honest and intelligent physician, for he or she must always ask one question, that at what price and at whose expense the success has been achieved. Nowadays, patient satisfaction is extremely important. Since 2000 till date, we have operated nearly 987 varieties of complex fractures, delayed unions, different types of non-unions, treated by original organ pattern Ilizaro technique. We do not use any kind of bone graft or related procedures to treat the sequelae of it. Compound comminuted intra-articular fractures, atrophic and all varieties of non-unions, infected cases or infected non-unions, big gaps, and the sequelae like osteomyelitis and cases associated with the neurovascular injuries are treated by Ilizaro. But before going for the Ilizaro, one should know why to use Ilizaro, where to use Ilizaro, and how to use Ilizaro. Ilizaro in union, sometimes or most of the times it is a biological and or sometimes it's a mechanical failure where Ilizaro comes to your hand. Most of the times nowadays the rate of infection is increasing, the cases are infected where internal implantation is rather contraindicated. Sometimes the fractures or the complex trauma comes with a deformity as well as shortening due to the bone losses. Where to use Elizero? Ranging from the aseptic or open or closed fractures, compound, comminuted or periarticular fractures, polytrauma. How Elizero works? Elizero gives very anatomical close fixation and is the most natural way preserving the biological aspects of the damaged tissue. Gives very stable fixation by minimal metal. That's why even though there is an infection, the infection won't proceed. Immediate mobilization and early union is possible, and that gives better functional results. Many of the times we add a corticotomy which increases local blood supply by 200 times. That's why we don't require any kind of bone graft or bone graft healing procedures, related procedures. It is a closed method of compression distraction osteosynthesis. Believe me, Elizero is the only system in the world which permits you dynamization. Dynamization means the ability to see or check clinically and radiologically whether the bone has or the corticotomy has healed or not till the fixator is on. So this is a very unique character of the Elizero, and most of the times it's a single surgery, and simultaneously it can correct the deformities, it can give the length, it can control the infection simultaneously. We have got a very strict protocol. We analyze all the patients psychologically, we counsel them, very good preoperative planning of the x-rays, and the methodology is done. As a rule, we do the closed osteosynthesis by original principles of Proudhon pattern. Sometimes we add corticotomy to enhance the blood supply as well as to correct the deformities and lengthening, and in cases of the infection, we ambulate from the same or the next day, joints are mobilized from the next day. Every 10-day dressing is done, and every 3 weeks the x-rays and physiotherapy is extremely important. Once you see the fractures or corticotomies they have united, radiologically, clinically we dynamize and we remove the fixator once we are sure that it has been united. We get two kinds of patients, and for the first time we have introduced the concept of psychological analysis of the patients, because we get two groups of patients coming to us. First group is fresh cases but taking too many advices, and that's why they are tense and confused which system to go. And second are the already previously operated cases, but they are failed, they are quite depressed, they are having the suicidal tendencies or not. That's why all of these patients strictly we counsel them, and as well as Elizero is such a distinct and different system that most of the times we form the Elizero support groups so that the patient intermingle and they exchange their ideas. Coming to few of the cases and some differences, maybe for the first time we'll be seeing the mini Elizero fixator for all the varieties of the complex trauma related to the hand. This was a crushed down near for the amputation. You can see the X-ray, totally crushed phalanges. Mini dorsally placed Elizero, suturing and debridement was done, it was salvaged, and you can see the fully functional system. Within 2 months of time, everything is healed and we have removed this external fixator. We have got a pelvic Elizero fixator to treat varieties of the pelvic injuries. This girl was 18-year-old and she was referred from another state to me. She was having a bladder injury which was earlier repaired, and you can see here bilateral superior and inferior pubic rami and vertical fractures in both the iliac wings. 6 fractures, and we have stabilized by closed way by Elizero. It has healed up nicely. You can see one distinct difference, that pelvis has become broad. So you can see we have, along with the fixation of the pelvis, we had given the 3 inches of the broad pelvis as a bonus because she was a girl. Immediately next day mobilization, fully functional, and this is the first ever documented pelvic widening surgery. Along with the fixation, for the cosmetic aspect, we have given her 3 inches of the bonus, wider pelvis. This is another controversial case. This was a case of compound fracture, 3 weeks old, and treated elsewhere. And when the patient came to us, there was a big pouring comminuted fracture of the distal end here. This was actually segmental fracture, it was missed, You can see here proximal tibia and distal. Only distal fracture was fixed, and there was the anterior tibial arteries. They were cut at the time of the injury itself. So what are the problems while dealing such cases? There was a severe infection, there was comminution and ischemia. Total zero blood supply below the ankle, as both anterior tibial and posterior tibial were cut. What we did with the Elizero, we debrided, we applied Elizero properly, we gave the antibiotics as per culture, dressing, and later on the skin grafting was done, and this limb was salvaged. He was immediately ambulated. The wound has healed here very nicely, and the fracture has healed within 9 months of time, both the segmental fractures. This was near for amputation, but we could salvage this. You can see the blood supply. Due to the collateral developments, the blood supply has increased, and this is the CT angiogram, which shows that distinctly there is no blood supply below the ankle line. And this is 1 year and 10 months follow-up. Sometimes we face a lot of challenges also, like this case of compound fracture, stabilized by external fixator, and there was a bone loss of nearly 7.5 inches. We did the proximal corticectomy and bone transport, and foot in such a long lengthenings, we need to incorporate the foot to prevent the equinus. And you can see such a huge 7.5 inches of huge regenerate in a single bone, in a single stretch. And this limb was salvaged. It took nearly 2 years for that, and this is, I think, the first ever documented case of such a 7.5 inches of lengthening for the first time. We get a lot of complicated cases treated elsewhere like this. These are the open fracture comminuted upper end of the tibia. That surgeon has stabilized by external fixator, and the primary grafting was done. The graft got rejected due to the infection, and he was referred to us in this condition. This was the initial X-ray picture. We stabilized by Elizero, and with the special Elizero hooks and wires, we don't require any plastic surgeon's assistance. Whatever was remaining, the skin on either side, we could gradually bring both the ends together, and you can see ultimately the wound has totally closed without the plastic surgeon, and the fracture was also healed. Sometimes controversy, complications and challenges, everything comes together. Like this patient of compound comminuted lower third of the tibia with lost navicular. Such a big wound. You can see here the navicular is lost, and comminuted distal tibia and fibula fracture. Of course, it was treated 3 weeks before in some another center in this fashion, multiple K-wires and external fixation stabilization. That thing, everything got infected, and patient went to another very big and renowned orthopedic setup in India, where in spite of repeated surgeries and frequent surgeries, lastly they told them, in spite of everything, he might land up into the ultimate fatal amputation. So here, the limb was at the risk. Along with that, he was newly married just before the accident, 3 months prior, and he was just 8 months before he got a good job. So here only the limb was not at the risk. Marriage and job, 3 things. So we debrided, did good dressing, culture and antibiotics, and we removed the entire thing, fixed with Elizero. Immediately from the same day, the patient got mobilized. Everything hit. Secondarily, skin grafting was done, and you can see nicely this distal and tibia fracture is united. Here also we have implanted for the lost navicular, and leg was salvaged. Not only his limb was salvaged, but his marriage was also retained, and his job also retained, and he got a bonus of his child. If you are treating such complex things, always you have to think so many things, along with the only fractures and complex trauma. This is another case of deglowing and comminuted intra-articular sternocondyle fracture with bone loss in a 65-year-old female patient. You can see here they could just stabilize and do the expensive plastic surgery. We removed the entire thing, fixed by only Elizarov, absolutely no bone grafting, immediate ambulation, and everything got united within 5 months of time. Sometimes we did such kind of patients of failed acromioclavicular clavicular joint here. Very simple fixation, but encouraging results. This is another interesting case of 1 week old fracture dislocation of the knee. You can see very swollen and posteriorly subluxated knee joint. With the femoral and tibial frames, the joint was gradually relocated, and you can see here there was the upper end of the tibia and fibula fracture as well. Everything has healed up. Not only that, the patient regained nearly 75 degrees of knee flexion, painful and painless and totally stable knee joint. In another case, 3-year-old dislocation of the knee joint with 30 degrees of the fixed flexion deformity. It was also gradually reduced, and we got nearly 40 degrees of the active knee flexion and painless and stable knee joint. Most of the times, compound fractures, immediately we debride and fix them, and we give the primary union not only of the soft tissue but of the bone. You can see here, there is no bar for the, he is a quite illiterate guy, but Elizarov works quite better in every condition. This is a compound floating knee injury, comminuted supracondylar and lower end of the tibia fracture, both simultaneously fixed, both got united with a fairly good range of movement. This is a 26/11 Mumbai attack case, and which was referred to us after 5 months of the treatment from Mumbai. This got injured, this tibia got injured by AK-47 rifle, Russian, totally shattered into, and it was fixed by this kind of tubular fixator, but there were no signs of union after 9 months. We removed the entire thing, we did partial fibulectomy, compressed and fixed everything properly, same day ambulation, and you can see miraculously the fracture has nicely healed. See here the irony, one Russian AK-47 injured and another Russian Elizarov cured it. Many of the times we get such infected fractures treated elsewhere by external fixator. We remove, fix by Elizarov, that's all. Here we give nearly good range of movements. This is a 2.5-year-old. These are the rather sequelae of the complex trauma, failed and treated elsewhere. 2.5-year-old infected non-union. It is a hypertrophic type of infected non-union. The problems here are the fibula and the nail was inside, and from the day one this thing got infected, but the infection kept on lingering for 2.5 years. Patient came to us in nearly septicemia with 2 draining sinuses. We removed the nail, fixed with only 4-ring construct and partial fibulectomy. Partial means nearly 2 cm of the chunk of the fibula we have to remove due to the compression in the hypertrophic non-union for initial 3 weeks, and later on distraction for the 3 weeks. That convert this fibrous callus into the bony callus, and you can see miraculously this wound has dried up within 1 week of time, and only for the 1 week we have used the antibiotics. And this has healed up nicely with only with compression and distraction. This is another case of compound fracture, nailed elsewhere, KDD was done. It got failed up and got infected. And you can see the antibiotic beads were tried here. That also failed. That couldn't stop it, and it went into the infected non-union with 1.5 inches of the shortening. We removed the nail and we did the Elizarov and the corticectomy here distally to compensate for the shortening of 1.5 inches and to eliminate the infection. Sometimes we get the stiffness if you apply Elizarov to the femur, but with the good and vigorous physiotherapy, you can regain the movement again. This is a quite interesting case. 3.5-year-old infected non-union of the upper end of the tibia and nearly 1 inch of the shortening. Initially he got treated by external fixator and was cancerous too. Later on it failed. Some another surgeon tried Elizarov. At that time the surgeon failed. Thirdly, everything was put into the plaster, but at the end of the 9 months it went into the infected non-union. And again, when the patient came to us, we did a proper Elizarov with corticectomy for the leathering infection eliminated, and with the second Elizarov is nicely united, clean length, frequency cemented, and the infection vanished. If Elizarov would have been tried in the first instance, all these serial failures would have been prevented. This is another case of the infected non-union of the humerus and with shortening, and infected non-union ipsilateral of the femur with 4 cm of the shortening with multiple failed surgery. You can see for the humerus, initially the nailing was done, it failed, then plate was done, and see what is remaining here. After removal of the plate, there was another iatrogenic fracture. So it was after the removal of the plate, it landed up into the segmental fracture of the humerus, totally osteoporotic, multiple holes and infection, many problems because of these repeated inserts or this living bone. Ultimately, we fixed it, did a corticotomy, everything united nicely. It resembles just like a flute. Same thing was for the femur. You can see the nail has gone outside. We removed the nail, 2 times it was nailed, and everything united very nicely up to. And this is the follow-up of 9 years. You cannot make out that flute humerus has been transformed into very nice original humerus, as well as the same is the situation for the femur. Sometimes we get the infected failed cases of the fractured neck femur, where you can remove an entire thing where internal fixation is not possible. Big gaps and infections can be dealt with corticotomy and acute shortening. Coming to the end, the corticotomy of the compactotomy tremendously improves the vascularity by 200 times. That's how we don't require any bone grafting or related procedures, which helps to heal up the layer of non-unions as well as to wash up the infection. As well as simultaneous lengthening and bridging of the large defects is possible with the corticotomy. Simultaneous deformity correction is possible, and it totally eliminates the need of the infection. Elizarov has got distinct advantages like it gives accurate close reduction. It's the most natural way by preserving the biology to deal with any complex trauma. It is semi-invasive, that's why it gives very faster and better results. It gives very stable fixation where the patient can be mobilized from the same day with nearly full weight bearing. Early ambulation is possible, better functional results with early movements are possible. Many problems can be tackled with the single surgery simultaneously, and more often gives very cosmetic results. Less complications and disability rate by the use of Elizarov, and it has got wider applicability to suit any indications. In result, we have got nearly 37% of the good and overall excellent results with few complications which are treatable. The mean union time was shorter than the conventional methods. Such result demands following the original principles of closed method of compression distraction osteosynthesis by Kurgan pattern. It eliminates the need of bone grafting and related procedures. Infection gets controlled with the limited use of antibiotics. Joint movements are better with Elizarov, and complication rate is quite less, and these complications can be very treatable and avoidable. In conclusion, Elizarov is the most advanced method. With this complication, it has addressed very effectively most of the challenging situations like polytrauma, compound comminuted fractures, periarticular fractures, and big bone losses and non-unions. If original Kurgan pattern technique is followed, there is no need of bone graft or related procedures to achieve the union. The greatest advantage is versatility, which has opened limitless possibilities to treat any complex trauma or its sequelae. But there is not one drawback. You need to have a very innovative and skillful brain. Once you know these basic concepts and the principles, you can make a team of Elizarov patients like this. Friends, even though Elizarov gives such a marvelous and magical sort of results, but the inventory is very simple. Only inventory is the basic concept or knowledge of the Elizarov, then you can practice in any corner of the world. That's why this is a trademark sentence by me. Elizarov is very simple, it's practical, highly effective, and versatile. One should know all these things, and that's my aim, to come down from India to here to tell you all these things. One, if you get to learn all these things, you can tackle any kind of such difficult kind of situations, and you can have a distinct upper hand over the conventional methodology. I had an opportunity to learn all these things from Kurgan, from Professor V.I. Shivasto, the former director of the Russian Scientific Center, And friends, it has been advanced that from the Ilithro has gone to the 4th generation now. But of course, even though the things look so decorative, nice, but for everyone it's not possible to go to Gurgaon and learn it. So actually it is a paradise for orthopedic surgeons to go there and learn so many things there. There are certain distinct barriers there. That one of the things is that Russia is full of beautiful girls. So I saw there most of the delegates, they forgot learning Ilithro and they went. Another is the cold, and third thing is the language. That's why to overcome all these barriers, we have started educating people in India and everywhere in the world by a lot of fellowships and teaching programs of Ilithro in India and abroad. And our center provides yearly 30 Ilithro fellowships annually. And our annual fellowship program starts in the 3rd week of the September. Thank you very much.
Doctor is going to speak to us about his experience in the power of realignment osteotomies. Thank you, Dr.
I'd like first to thank the organizing committee for this chance. Thank you all. And I wouldn't say anything rather than I feel home. And I think it will be enough for all the hospitality we felt yesterday. I won't waste any time. My talk today is about the power of biplanar osteotomy in management of pathologies around the knee. And of course, to start with, we all know why to do osteotomy. This is for load redistribution, stop disease progression, preserve joint mechanics, improve symptoms, delay the input of metal and plastics as we do it primarily rather than to do it on a revision basis. Is this everything? No, never. We now understand better how to do osteotomies. We now plan better. We have better techniques, wider indications, and better results. And we're going to go through all of these in the next 20 minutes. Is it still a procedure of buying time? I doubt the answer if it is yes. I think it is a permanent solution for many people, and we're going to have some cases by the end of this talk. We have sustainable osteotomies and repairs and many clinical and technical details. It's rather a school now. We have Roland Varden, we have Alex Stobli, we have Philip Lobin-Mufa and Roli Yacoub, many pioneers. We have dedicated courses for osteotomies around the knee. In degenerative pathologies, of course, we have Adrian Wilson, the chair of Basing-Stoke Knee Osteotomy Masterclass that has been repeated over the last 10 years. We have Luxembourg Osteotomy Congress, headed by Roman Stein, the current chair of the ESCA, and Dietrich Spaten, many other pioneers all over the world. It's rather a school, as I told you. So we understand better now. And we're planning, we started to do plan on digital basics. We can even draw the osteotomy and know exactly where are we going to be and how much in a very high degree of accuracy that we are going to correct. For the techniques over the last 10 years, we have far achievements. We have very good achievements over the last 10 years. We know now how to get in, how to deal with the pest, how to open the wedge, and how to maintain the wedge, how to maintain the hinge point, and we discussed many of these issues yesterday in the course. While biplanar, it gives far more mechanical stability, it gives better healing potentials, of course, as the surface area is increased. It is a very strong implant, stronger than the former implants, with less frequent critical situations. We use the Tomofix or any other locked proximal tibial plates, condition that we understand the concepts of how to put the golden screw and how to compress the lateral hinge. The results are far more sustainable, far more better than before. We have an abundant literature about osteotomies around the knee and how it gives us better and sustainable outcomes in relation and in comparison with early arthroplasty, of course. I'll show you, this is an example of one of my cases that has been done around 12 years ago Forget about the X-ray, because in many occasions there is some discrepancy between the radiological and the clinical outcome. This patient is still doing well so far. I have done it while she was around 47, 48 years of age. And let us remember some of the basic concepts of biomechanics. The concept of contact pressure, that equals contact force, reaction force divided by the surface area, and of course each item of this equation is affected by certain factors like body weight, muscle power, and very importantly overall alignment, and as well the surface area is affected by the consistency of the recipient surface, force absorption, by the motion stability of the recipient surface, and by the sloping of the recipient surface, which is another very important point that I am going to come across it over the next few slides. This is to show how fast is the deterioration of the articular cartilage of the medial and lateral compartments of the knee, and I don't have enough time to go through the details, and this is to show how far as well is the deterioration of the articular cartilage in cases of shear forces implied over the articular surfaces. Consequently, the indications have been stretched over the last few years. We have corrections of symptomatic malalignment, of course, at all planes, coronal, vertical, and even the axial plane for disorders around the patellofemoral joints. We do osteotomies for protection of our repaired cartilage or meniscus. We do osteotomies for failed osteotomies. We do osteotomies for post-meniscectomy syndrome, and many other indications that I'm going to come across it over the next few slides. This is Fielker, down to the extreme west of Austria, at which I had some of my training around 12 years. Here are a few examples of the cases that we have done over the last 5 to 7 years. This is a very simple case, of course. There is deformity with failing medial compartments and severe pain, and this is the end result. And again, the medial compartment is still showing considerable degenerative changes, but the patient is, on the other hand side, is pain-free. For valgus deformities, this is another very obvious example, and this is here on the right side, the arthroscopy of the medial compartment. How brilliant is it? And on the other hand side, this is the lateral compartment, how degenerative is it? And this is a lady, 36 years of age. What can we do for her, apart from doing osteotomy, to have realignment, and to do it femoral, if the deformity is femoral, and tibial, if the deformity is tibial, as of our discussions yesterday in the course. Another indication is the post-meniscectomy syndrome, and this is a situation that I'd rather wish not of any colleagues to fall in it if it's not indicated. After removing the meniscus, the whole compartment would be so bad. And this is one of our patients that have been kindly referred to us from our Professor Hisham Saghir. I think he's among you now. Around 7 years ago, she is 28. She was 28 at that time, and she had a body mass index of around 40. And she had intolerable pain on the medial aspect of the knee. This is her alignment. This is the medial compartment, completely devoid of any meniscal tissue. And this is, again, the coronal cuts, the femoral condylar surface irregularities and subcondylar bone cysts are very clear, and that was our solution for her to realign. And this is our final results after getting the implants off. Another very important indication is the ligamentous insufficiency around the knee. If you had a patient like that, chronic ACL deficient knee for 8 or 9 years, and this is his alignment, we shouldn't ever forget to check the alignments in every single patient having a chronic ACL deficiency, or even sometimes acute among the top athletes. And this is a very important note around the medial slope. See the left-hand side picture and see the slope of the medial tibial plateau. How is it very much increased? There is even some evidence now that we should do some kind of screening or checking for top athletes. If they have that increased slope, we might not recommend them doing some kind of collision sporting. And that was the recommended treatment, to do combined correction of the malalignment together with ACL reconstruction. However, we sometimes not do anything regarding the ACL deficiency if the situation does not allow. This is a 40 or 42 years old lady with chronic ACL deficient knee. Again, she has a degree of malalignment, and she started to complain of pain more than to complain of instability. This is her scope on the right-hand side. You hardly can have any working fibers of the anterior cruciate ligaments, and the recommended treatment was on the left-hand side to do high tibial osteotomy to correct in both the coronal and as well as the slope deviation. So we sometimes find it enough to decrease the slope and correct the coronal malalignments without doing any reconstruction for the cruciate ligament. As this is a lady around 40-42 years, and I'm sure most of you in common with sports injuries and know how difficult is it to find a good graft in such a lady around this year. The CMT would be very flimsy and the patellar tendon would be very short and so on. This is another very good example of cases having failed osteotomy. This is a gentleman who had seen us around 6 or 7 years back, and he had this malalignment, and he went somewhere else and did this kind of correction. If we carefully looked at this X-ray, we can recognize that there are many problems. There is lateral tibial translation, there is valgus deformity, and there is delayed union, of course. And most importantly, there is very much increased slope. So the clinical picture was for this patient like that, with obvious valgus and severe pain for the non-union. This is his CT showing non-union at the osteotomy site. And that was, alhamdulillah, our treatment for him. We planned for all of his needs and did it, alhamdulillah, in the same time, and this is our result. So from this slope on the left-hand side to the correct slope on the right-hand side, and from this situation to that situation for the left hand, and from this situation to, alhamdulillah, normal alignment of the knee. Another example for interarticular deformities, which is rather a more difficult situation if the patient had any malalignments after tibial fractures, like the lateral tibial plateau in this patient and in union, of course. And we revised everything. We recreated the fracture, we put a graft, we elevated the depressed fragments, and we put the osteotomy line passing in through the joint line, which is something needs some tawfiq from Allah subhanahu wa ta'ala and some experience. On the left-hand side, that was the alignment and before surgery, and on the right-hand side, that was the new plate and the new alignment, but I didn't have a stitch film for this patient here. Another indication are complex deformities. This is a 17-year-old gentleman with neglected Blount's disease. All of the ankles are very much disturbed, having around 20 degrees of varus deformity. And the most important finding is the oblique joint line, as you can see here. I'm not sure if the cursor is shown up or not. Oblique joint line from lateral to medial. It's not allowed to be any more than 4 or 5 degrees. This is around 12 degrees. And we planned and did some staged procedure. We first increased the varus deformity to have a joint line that is parallel to the ground. We believe this is very important. And then we downstaged or downgraded the deformity of the tibia by a 16 degrees correction. And then 18 months later, on the left-hand side, that was the re-evaluation of his long leg standing fill. And on the right-hand side was the very recent procedure done to complete the procedure and do osteotomy or re-osteotomizing the already osteotomized proximal tibia after being completely healed. Another very important indication is the reversed slope, and this is a girl about 14 or 15 years of age. She's a gymnast, and she used to have marked recurvatum deformity, and she used to have repeated falls. She did even a scope for a supposed meniscal injury, and was told that she has something wrong about her posterior cruciate ligament, while the real problem was never like that. The real problem was reversed slope. As you can all see, I don't like to waste your time. This is the slope, the abnormal slope of the abnormal knee, and this is the normal one. And that was our treatments for her, alhamdulillah, by getting the slope back to the corrected position. I now do not profusely use Podo plating, but I found this patient is an ideal candidate for putting 16-degree Podo plating to correct the slope. Another very important indication is protection of our repair to the meniscus or the cartilage, and this is a lady around 45 years of age having symptoms and signs of failing medial compartments. As you all see, bone marrow edema of the medial compartment in the MRI, and this is her stitching film with obvious virus, and that was our treatment for her. What's important about that patient is that this is 1 year later, and she complained of the plate and asked it to be removed. And while removing the plate, we scoped her to find what we are going to show you now in a minute. This is the pre-scope, the scope while we've been doing osteotomy, and we found that root tear of the medial meniscus. And as I told you in the beginning, it is some kind of a tear that is occurring in response to intolerable loads to the meniscus. And when we find that kind of tear in the MRI, we should suspect malalignment. We decided for some reason to do a repair of this root tear. She was young enough, having a good body mass index, but this is not our usual practice. We do not repair all root tears for degenerative pathologies. We did a tunnel, we passed the sutures and did repair in the first surgery. And then rescoping her 11 months later. That was the situation. I myself was astonished of this result. I found the medial meniscal root tear completely healed, like what you can see now. Probing of the area of the repair. Very still. Again, protection of the lesions of the cartilage. This is around 63 years old colleague physician, and we don't look to the age now as a contraindication. It depends on the age of the knee, not the age of the patient. He's having that X-ray around 8 months prior to his presentation to us. It wasn't clear enough. And this 8 months complaint X-ray, when he presented to us, having this kind of AVN at the proximal medial tibia. It's also apparent here on the lateral X-ray, and this is his MRI, all the signs of failing medial compartments on the tibial side, not as it is very commonly seen on the femoral side. And this is his alignment, and that's his scope. This is the femoral condyle, this is the meniscus, and this is the lesion on the tibial plateau on the extreme medial aspect of the tibial plateau. A lot of debris, broken cartilage. What we have done is debridement of all dead tissue and pieces. We did what we call submeniscal portal to have an easy access to the lesion. Introduced our curettage, which is a very simple and very beneficial tool to clean all the dead tissue. And then introduced the ruler to see how is it sized, length and width, to plan for grafting. And some drilling of the base of the floor to get some fresh blood. And this is the graft coming in. Fix it with this metal screw that we can see. And this is the post X-ray, still not having a long leg film because this is very recently done. And this screw, of course, to fix the graft. My last patient was around 40 years of age, having this medial chondral damage, as we can all see, failing medial compartment. And this is his stitching film, his long leg film, some degree of burst. And this is his scope while doing osteotomy. meniscus is just fine, he's just 40 years of age, but will have this horrible cartilage defect, grade 4, ICRS, exactly located at the weight-bearing area. We did some microfractures, and we did him very usual high tibial osteotomy. And this is the follow-up X-rays until 4 months later, full healing. But this patient asked to do a definitive procedure, as I've told him from the start that we have just done microfractures. I didn't believe that we are going to have any good results behind that. And he put that into consideration and stopped working, waiting for the definitive procedure that I've told him about, to do some form of oats. And he was persistently asking to do the definitive procedure, although I was feeling that there is some good healing in the X-rays and the MRI as well. But he was persistently asking, and we prepared ourselves for some definitive form of cartilage management. That was the arthroscopy beforehand, and that, surprisingly enough, was the arthroscopy after only 4 months of treatments of cartilage, accompanied by doing realignment procedure. This is how nicely healed the articular cartilage defect, and that was how deep the articular cartilage defect. And I think the reason behind that is that I believe in the power of osteotomy. So please believe it and believe in it as much as I do. Thank you very much.
Thank you, Professor Akram. We can now open the floor for questions, please.
Been telling this is a very important kind of tissue in certain needs for load absorption and many other functions, and day after day we increase our concern in having this meniscal tissue preserved in certain need. Of course, we have the already established post-meniscectomy syndrome. We have already established the 20 years follow-up studies of Professor Verdonk after meniscal repair. It definitely makes a lot of difference if you preserve the meniscus. But this particular kind of patients having meniscal root injury, I think it can be considered some kind of over-treatments if we repaired the roots of the meniscus without having any realignment, as the reason is still there, because it has ruptured because of the load on it. So we should underload first, and then if we're going to do repair, we'll do it. And it will work, as we've seen.
Yeah. Do you do it in the same session or in 2 sessions?
Yes, same session. Always same session. If you don't, I think probably one of the procedures would fail. Just when you do post-operative corner repair, if you divide them in many cases, what you reconstructed would probably fail. Because the burden, the loads, will not be distributed as it should be.
Thank you very much, Professor. I think we have coffee break. Thank you.